Good afternoon, Dr. Odum. Thank you for your time today. As you know, the 1st of June represents 12 months since the beginning of VI. As you're aware, the Trust receives many questions almost on a weekly basis about this exciting programme of work. And it's only fitting and appropriate that, given that we've reached a kind of a major landmark, we pose you some important questions as a way of an update for the public and kind of clinicians in the city. Okay, so just to begin, may I ask, what is the Trust's motivation for integrating with primary care practices?
The Trust's motivation for integrating with GP practices is, in essence, around delivering a more appropriate and better care for the population of Wolverhampton. The model of care that we deliver now across the primary and secondary care interface is disjointed. It does not work particularly well for individual patients on their individual pathways. The model of care that was designed in 1948 is no longer appropriate in the 21st century. And essentially what we are trying to do with primary care is to construct better pathways of care that allow patients to be managed closer to home, but when they need to attend the acute trust for their urgent or emergency care needs, they can do exactly that. But it's really to streamline and provide better care pathways for the population of Wolverhampton.
It's not traditional territory for a large acute trust like this to go into. Why did Wolverhampton take this approach?
So the acute trust is funded in a particular way, and the way that the mechanisms underpinning the funding of acute care does not necessarily serve the needs of the individual patients. So if you're looking actually at the care of the individual patients and where that can and should be delivered, and in many cases it is not up at the acute trust, then you need to look at different ways in which clinicians are delivering that care. So we would like to see the acute trust delivering urgent, emergency, high-level, elective, critical care, tertiary service delivery on site. But that doesn't necessarily mean that we need to be delivering all the urgent care and other care that can be provided closer to home, largely to a frail, elderly and other population.
Oh, excellent, thank you. Primary care, by all accounts, is a much-loved institution. We know it's challenged in terms of resources. There are issues with chronic shortage of GPs. We hear about the ever-increasing workloads in primary care. Can I ask what VI has done to address some of these issues? What plans you have placed in the future?
Primary care clinicians, GPs, are worth their weight in gold. The vast majority of patient care is delivered outside the hospital setting, in the primary and the community and in the community arena. What we do know is that the model of delivery of primary care has changed dramatically, and the demands on the primary care clinicians is now overwhelming. What the newly qualified GP trainees are telling us is that they do not want to be delivering care and a service in the way that they see. The demands are demanding that is delivered out in primary care, and they want to see a different model. So whilst we know much of the care for patients is delivered out in primary care, the attractiveness of trainees taking up those posts is diminishing, and that is why there is a shortage of GPs nationally. Can I see that? Yes, of course I can see that, because I see my colleagues out in primary care busting a gut and being on a hamster wheel to deliver the care for their patients in a way, frankly, they're very frustrated with and want to change something. So in terms of the primary care clinicians and the desire to do something different, we believe that by taking down the boundaries between primary and secondary care, we can help our colleagues out in primary care deliver services in a different way, whilst ourselves contributing to the delivery of care out in the community and supporting our colleagues there in a way that's most beneficial for the patients.
Right. Clearly, you've done quite a lot of work in the last 12 months or so. Can you talk through some of the highlights that the patients will have seen at the practices so far?
Yeah, well, so there's been a lot of work done out in primary care to enhance the facilities and the service provision for individual patients. So, and also to make the efficiencies of delivery of care out in primary care better. So there have been enhancement to the telephone receptionist service, which we know the patients appreciate. We know that by looking at different models of working and looking at capacity issues and creating efficiencies, that we can create extra slots for seeing patients out in primary care. There have been an extra 4,000 clinic slots or surgery slots made available as part of our process. The clinicians in primary care and secondary care are also working closely together to look at the pathways of care for different groups of patients, some of which are the frail elderly who are heavily comorbid and how they may be better cared for by joint working between primary and secondary care clinicians. We've looked at end-of-life care and how that could be better supported by our secondary care and palliative care clinicians working with the community teams and primary care. We've looked at how we can develop proper MDT type working between primary and secondary care by using live integrated databases, which gives a real-time profile of the individual care needs of individual patients and allows us to focus in on those high-risk, high-demanding patient populations or individual patients perhaps to allow us to target them through an MDT process. There's a project to look at how we can deliver better and perhaps more appropriate care for cohorts of paediatric patients out in the community. So there's a number of different projects which are going on which are actively delivering better care for both the staff in primary care and the patients. And there's a number of projects that we believe will fundamentally change service delivery and outcomes for a large number of patients from the young through to the very elderly in due course.
Thank you, Jonathan. And there's lots of published literature to say any kind of major transformation program relies on kind of a really strong positive relationship between the different stakeholders, elements of trust and kind of mutual understanding. What would you say your experience of kind of the relationship has been between the GPs and the secondary care clinicians as part of this kind of integration program?
The relationship between the GPs and secondary care clinicians has been overwhelmingly positive. It has been one of the most significant developments that I've seen in the last few years. So the secondary care clinicians who understand the requirements of delivering secondary care, they fundamentally want to see secondary care delivering, as I've said earlier, the acute, the emergency, the tertiary services, the hot services, the critical care services on the acute side. But they can absolutely see the requirement to be delivering the primary care services out in the community with the primary care clinicians. And stripping down those boundaries between primary and secondary care and allowing two different types of clinicians to work together within the same organisation has fundamentally changed the way that the practice and the service is now being delivered between what is now one organisation and which was previously two. So the relationship between the GPs and the secondary care clinicians is just like any other two colleagues working together without having any boundary between the two of them. They work together, they talk together, they develop pathways together, they discuss the MDTs together, they talk about projects together. They are essentially clinicians with different skill sets who are now able to work together in a single organisation to the benefit of the patient population out there in Wolverhampton.
Fantastic. We know that more and more practices are looking to join the VI programme. With that happening, what is your vision for the future, Jonathan? What's going to happen next?
The vision for the future is an interesting one because I think the 1948 model of service delivery is just anachronistic and completely outdated, and the 5-year forward view refresh has supported that. So out there we need to be looking at different models of care across health economies, and in my view the most advantageous one would seem to be looking at an accountable care model where there's integration of primary and secondary care and community services, and probably other partner organisations as well, in which you're looking at the overall health requirements of individuals and cohorts of individuals within that health economy, but without any boundaries between them, and certainly without any of the contractual basis of funding that we have at the moment, which seems to drive certain elements of clinical services largely on a remuneration rather than an outcome or appropriateness of care item for the individual patients. So what I would like to see is the Wolverhampton health economy develop into an accountable care model which works on a capitation basis, and that looks after the whole care needs of an individual patient and the cohort of patients and the population of patients in Wolverhampton, irrespective of whether that's a primary care service, whether it's a secondary care service, a community service, a tertiary service. But it means that all the clinicians and the partner organisations need to come together to essentially deliver that model.
And given the hard work that you and your colleagues have done, are you optimistic about the future?
Am I optimistic about the future? By nature, I'm an optimist. And I would like to see, from the work that's already taken place between primary and secondary care, the delivery of the accountable care model. I have no doubt that that can be delivered. It will take some hard working between primary and secondary care clinicians to get the models right. It will require funding to be moved around the system to accommodate the different pathways and the care needs of the individual patients. And that primarily involves taking some funding away and out of the acute trust to allow that care to be delivered in a different way. But I don't see that as being in any way unachievable, just the opposite. I think where there's a will to deliver that better care and most appropriate care, and if you're looking at accountable care models and organisations across the world, essentially they are looking they are based on outcome measures. So it's years of life, it's quality of life, it's living longer with long-term conditions, it's taking on the public health agenda, it's delivering, supporting our public health colleagues in delivering what we know is important both in the early years and the later years. But I think from what I've seen in terms of the research that we've done and the models of care out there internationally, I think it is absolutely achievable. And I think it's down to the partner organisations in Wolverhampton to actually get together and achieve on that model.
Dr. Odum, thank you very much.